Relative value units, what are they and why they matter? People in healthcare talk about relative value units, or RVUs, all the time. In the healthcare world, many people understand RVUs, not for what they actually are, but for a tiny sliver of what they're used for. For instance, work RVUs, or WRVUs, are frequently used throughout the United States to measure clinician work and to calculate clinician compensation. We talked about WRVU-based compensation models in our video, Physician Compensation in a Hospital. Let's look at a simple example of a WRVU compensation plan. Dr. Smith is employed by Hospital Y and is paid $40 per WRVU for work he performed at the hospital. If he delivers 12,000 WRVUs during the calendar year, he would generate an income of $480,000. In other words, $40 times 12,000 work RVUs. This is not the money that Dr. Smith generates for the hospital. Instead, it is simply what they pay him. Side note, the hospital should generate a lot more revenue than what they pay Dr. Smith. This overly simplified example paints a picture of how WRVUs translate into compensation for clinicians. Most health systems have some form of this compensation plan, and some private practices have WRVU compensation plans too. As we've discussed in other videos, CPT codes are the elements used to bill for your care. As you can see, each CPT code has a different work value dependent upon the CPT code documented and billed by your clinician. For instance, if you're a new patient to a clinic, new patient CPT codes 99202 to 99205 have work values between 0.93 and 3.5. Remember, as we've discussed, the complexity of a visit means a higher CPT code work value. Return or established patient visits, CPT codes 99211 to 99215, have work values of 0.18 to 2.8. While work RVUs are 90% of the talk about RVUs in the healthcare space, they're the tip of the iceberg in terms of what RVUs actually are. RVUs were a creation out of Harvard in the late 1980s and were deployed via Medicare in the early 1990s. RVUs are utilized to arrive at the allowable reimbursement for a healthcare service, that is, what a clinician is paid for the service. Generally, RVUs are comprised of three component pieces that are adjusted by geography to deliver a payment rate. The reason this occurs is that RVUs recognize, in theory, the differences in the cost to practice medicine in different areas of the country. For instance, it is arguably more expensive to see a patient in New York City than it is to see one in the middle of Iowa. So payment for a service based on CPT includes a WRVU, a malpractice RVU or MRVU, and a practice expense RVU, a PE RVU. These values in theory take into account the work effort required to deliver the service, the malpractice exposure, and the practice overhead or costs associated with performing the CPT. While these values can change every year, the base RVU values are constant throughout the entire U.S. for any given year. This formula delineates how Medicare arrives at payment rates for CPT codes. The RVU component pieces are multiplied by geographic practice cost indices, or GPCIs, and the sum of these products is then multiplied by the conversion factor, or CF, to arrive at the geographically adjusted reimbursement rate for a CPT code. GPCIs are deployed to allow for cost differences in the delivery of care between different areas of the country. WRVU times WGPCI plus PE-RVU times PE-GPCI plus MRVU times MGPCI times CF equals the Medicare allowable. To understand the math and how the payment is derived, let's examine reimbursement for a 99203, a Level 3 new patient visit, in Atlanta, Georgia, Richmond, Virginia, and the entire state of Iowa. These amounts are what practitioners get paid by Medicare for a 99203 in each of these geographic locations, respectively. As you can see, the work value, or WRVU, of the 99203 is static, but the work GPCI adjusts the work for any geographic location. The same logic follows for the practice expense and the malpractice RVUs, 1.59 and 0.16 respectively. In our example, the practice expense GPCI in Atlanta is 0.997, in Richmond it's 0.984, and in Iowa it's 0.913. It helps you understand that it costs more to practice medicine in Atlanta than anywhere in Iowa. In Atlanta, the math is 1.6 times 1, plus 1.59 times 0.997, plus 0.16 times 1.128, where that total, 3.37, is multiplied by the CF of $32.74. So, a clinician in Atlanta who bills Medicare for a 99203 receives $110.19. In Richmond, he receives $107.67. And in Iowa, anywhere in Iowa, he would receive $102.31. People in the healthcare space frequently talk about RVUs, but that talk generally revolves around work RVUs. Today's video offers a broader understanding of total RVUs and how those impact Medicare payments based on where the clinician is located. As with our other videos, this video is not meant to answer all questions precisely. However, all of CUBE's videos are directionally accurate across the United States. Some nuance exists geographically. Healthcare really is local. Please subscribe, like, share, and if you have any questions, email them confidentially to questions@cube.org. Stay tuned for our next educational video.